Hi, I'm Mike Bailey. I'm very happy to represent our group on our work with NASA. Thank you for the opportunity to speak to the NASA community. Here's my disclosure. We're attempting to test a new ultrasound technology to mitigate the renal stone risk in an emergency department, and these are the 4 questions we're trying to answer. Can they locate stones? Does the therapy work? Do they tolerate it? And are there additional risks? The renal stone risk from the HRP roadmap is a very high risk with severe consequence and high likelihood. And the roadmap continues with the evidence for that. There are reasons that the stones form in space. They have formed in space, and they are critical to mission success. We are testing a treatment intervention for the treatment side of mitigating the renal stone risk. The risk is that in the kidney, the fluid, the urine, fills the kidney, flows down the ureter to the bladder. A stone will flow down into the ureter and block that. And then you'll have buildup of urine and pain behind it. And that is called hydronephrosis. It can also lead to sepsis as the bacteria are driven into the blood. I'll mention the UVJ down the bottom underneath the bladder as it kind of wraps in. That's where most stones get stuck. They can also get stuck at the UPJ up near the kidney. Generally, once we get through the bladder, into the bladder, it's free sailing from there. What we have is a handheld ultrasound to target, detach, and break, and then actually move the pieces with the sound waves so that the stones will naturally clear. And we have awake patients that are on their back or side. We generally put the probe about where the star is on their belly button. And this is kind of the positioning that's been used for ultrasound imaging in space on the right. It's minimal hardware upload, a small power supply, and a therapy probe. Those then mate with the existing imaging probe and imaging system for guidance. We use a University of Washington system. We've also integrated it into NASA's flexible ultrasound, and there is now a commercially available product to do these things. The controls are all software. We do use the twinkling artifact, which is shown on the left, lighting up the stone in green to help identify the stone. Otherwise, stones are bright white on the right with possibly a dark shadow behind them. This is a look at the probe again. The black is the therapy part, the red, the imager. We measure the outputs as pressure versus time, the sound wave itself. And we have 2 settings that we're going to use on our subjects. One is ultrasonic propulsion, lower amplitude, longer pulses. The other one is propulsion plus dislodging pulses. The dislodging pulses are shorter and stronger, and they try to shake the stone loose. Studies all approved. This is a summary of our protocol. We have a system to recruit subjects. They all have a CT beforehand. Generally people with stones and without other illnesses to exclude them. We get a pain test 0 to 10. Then we image them. We look for hydronephrosis as well as the stone. We ask them again, how are they feeling? We then attempt to move the stone. So we use the sound waves to either try to push a UPJ stone back in the kidney, which will relieve their pain, but then they'll have to get surgery later. Or we can try to move a distal ureter stone back away from where it's stuck so it might flow back through, or push it into the bladder. We then image for hydronephrosis and get a pain score. We follow them up to see if they pass stones or have adverse events. and we get imaging to see that the stone has passed and hydronephrosis has resolved. These are our study endpoints: motion, passage, pain reduction, hydronephrosis. In addition, we're looking for adverse events and or tolerance of the treatment. We recruited 42 people, 23 were treated, one was lost to follow-up. Really, we couldn't see the stone in 5 of them well enough to treat at least, and others moved to a location we didn't want to treat. Some were too deep for our current probe, but I don't think there's a technology limitation to a different probe that treats deeper. This one's a really nice result. We had this person drink water, roll on his side a couple times as we imaged to try to align the stone. And in that process, we were able to roll the stone just naturally from the UPJ into the lower pole of the kidney, where it stayed for several weeks until he could come back for surgery. And so we immediately relieved his pain and it didn't come back. So then we had pretty broad demographics, should encompass astronauts. This is our primary result, stone passage. Up top, we show the extensive literature and meta-analyses of the natural course of a stone. So a distal ureter stone will pass 54% of the time in 7.5 days on average. Our results are broken up into different groups down below, but really all of them showed overall 93% of our subjects passed their stones in 3.5 days. If we look at just those that were treated with the propulsion, 89% passed in just 1.5 days. In addition, the group with very chronic stones that we treated with propulsion and dislodging, 2/3 of those passed fragments of stones. So we have a significant improvement in the number of percent passage as well as the number of days to passage, and really we're better or comparable to the existing options that patients have for surgery or medical treatment. We met that one major endpoint. We also met the other endpoints. We moved 3/4 of the stones, 1/4 of them moved a distance of 3 millimeters or more. We did not see hydronephrosis resolve right away, but it did at the end of our follow-up. About half of them had a decrease in pain level. And in fact, many of our patients were asymptomatic when we treated them, so we couldn't improve their sensation. So how does it work? Well, we can these show the ability to move the stone. So on the left, we move a stone down into the ureter, and then it comes back toward the bladder. So we're moving it within the ureter. That same stone then we're able to push into the bladder where it is free. That patient felt immediate relief. Also, when pushing the stone that is free in the bladder, we see the gravity can make it roll back a little bit. That would be different, obviously, in space. So motion's one of the mechanisms. The other one we discovered is the ability to perhaps stimulate with each push pulse this jet. So these show the ureter jets. The urine is physically squeezed with a peristalsis motion into the bladder, looking from the bladder and on the ultrasound. If you look right where the X is, there's a little, you can see that jet come out. It goes blue, that ring, as soon as we've completed a push. So as soon as we complete, the thing jets. And so that's the second mechanism, and 9 of the 20 showed a jet. And then the last mechanism is that we can break the stone so that the pieces are easier to pass. This is a broken stone afterward in surgery. And if you watch the ultrasound video, you'll see a little piece come off the white thing in the X at about 1 o'clock. So there it is. And then we have cracks on a passed piece. So these dislodging pulses, not the propulsion ones, but the dislodging have the ability to break up the stone, and that's now used in patients in what's called VWL or burst wave lithotripsy. Then lastly, we've had these benefits. What are the risks? They're small, there are few of them, they're mild, and they are self-limiting. I'll talk, here's one of those three adverse events that we saw: skin, pink skin or red skin. The other one, gross hematuria in this very fine sieve that's used to collect stone fragments. The last one is, what did it feel like for patients? Well, about half felt warming of the probe, about half felt this sense of needing to urinate or pass the stone. Neither of those was necessarily bad. It was often good for these people. They felt like something was happening. Some felt a small vibration at the stone. As for pain, 3 people on 3 individual bursts out of 600 felt a pinprick, level 1 pain. And 1 patient who was asymptomatic reported afterward that the pressure of pushing had caused him a pain of 2. So really pretty minimal negative sensation from this treatment. Patients tolerated it well. And it really isn't a long treatment. It just adds a little bit to the standard ultrasound diagnosis. We did not have a control group, but you see there's an extensive literature explaining the passage of stones. We took a broad group of people, stones in the upper and lower ureter, which is nice to show its robustness, but we think we might want to fine tune that to really optimize the pulses for different situations. Also, we would call only after a week. Some people simply said, I passed a stone, and it may have been 10 minutes after treatment, it may have been 6 days, so we had to put a week. It'd be nice to resolve that more closely. And we only treated once, where we could potentially treat a second time for some individuals. So in conclusion, in this study, we tested a new ultrasound to address the risk of renal stones, and we worked in the emergency department as a space analog. Our results showed that a broad group of operators could successfully target the stone and do the treatment. We measured several benefits. The patients tolerated the treatment, and there was minimal risk to the subjects, and there's minimal time commitment. Our understanding is that NASA intends to use these results to now downgrade the risk of renal stones to say it's been accepted risk disposition. We appreciate very much the close work with NASA and XMC. There's a link to our work, and we would like to continue working with you either on muscle wasting or pneumonia. We also continue work with stones. Here shows us what we call acoustic forceps, the sound wave picking up the stone and then moving it in a controlled fashion within the bladder. Thank you very much for your time.